My name is Mary Lloyd Ireland, and this talk is about X-rays, what plane views, and when to order advanced imaging. This was presented at the Essentials of Sports Medicine, from the Sideline to the Clinic, formerly the American College of Team Physician course, Part 2. The course was in San Diego, February 2017. The learning objectives: know the images and position of the patient to order for certain diagnoses. Understand when to order advanced imaging after plain X-rays. I have no disclosures. This is the different sections of this talk. Introduction. We'll do lower extremity starting at the hip and going all the way down to the foot, and then conclusions. When we think about high-risk stress fractures, low-risk stress fractures, we need to look at an algorithm. And this algorithm was from 2000, Bowden. If you suspect a stress fracture, you start off with plain X-rays. Sometimes it's good to get a cone-marked X-ray, in other words, an X-ray that's a little closer up, and put a marker over the area of suspected stress fracture. If site or duration of symptoms warrant, the next step would be an MRI scan. In certain situations, if you suspect more of metastases or more of a systemic problem, you might do a bone scan. Or if it's a more complex bony problem, you might do a CT scan. But in this time, we would usually go to an MRI scan after plain imaging, do the imaging first. And so this algorithm, and I would have you read this article, talk about where we go from there. So a negative radiograph, non-operative treatment, negative radiograph but positive advanced imaging, go to the diagnosis of what type stress fracture it is, determine if it is a low demand athlete or a low risk stress fracture, like on the compression side of bone. Then we go non-operative treatment. If it's a fracture located on the tensile side of the bone or a high demand athlete, this may require surgical internal fixation. High-risk fractures are on the tensile side, as you can see here on the left. That's a Jones fracture. Fifth metatarsal fracture at the diaphysis-metaphysis junction. You can see how thick the cortex gets, so the body is trying to heal this, but this is on the tensile side of the bone, and this is a fracture that will not heal and needs to be fixed. Typically now we're fixing it with an intramedullary device, a screw, and usually this will heal. Early diagnosis is key. In the hip, the problem side is the tensile side up here. The compression side is here, so if you have a stress fracture that involves the tensile side or the superior aspect of the femoral neck, then that's a situation where early operative intervention is indicated. The dreaded black line of the tibia is here, so this was actually a marked view, dead on, right where the fracture was. Usually there'll be a localized swelling and perhaps some type of a deformity where they're more bent or more concave on that side where this dreaded black line is. And look how similar that looks to the Jones fracture, where the cortex gets thick, but this is a tensile side of the bone, a high-risk fracture, and the treatment for this is an intramedullary rod, so we don't really have to do anything with the fracture itself. It will go ahead and heal if detected early and treated with intramedullary fixation. Again, tensile side of the bone. Problem: high-risk fractures. Early diagnosis and intervention results in a good outcome. The lower risk are the compression side of the bone, so the metatarsals mid-shaft, diaphysis. You can see these on plain films. So this is a thickened second metatarsal stress fracture that is healing. The compression side is the inferior aspect of the femoral neck, and this is an example of a fibular stress fracture. You can see how thick that cortex has gotten, and this is a fibular stress fracture, a low-risk compression side that will heal with modification of activity but doesn't require surgical intervention. Plain radiographs in the lower extremity. If you can get your partners or clinic or department to do standardized view, then this is very helpful so that you can compare them year to year, create and agree within your group or department about these views, special views, marked cone views, stress views, and comparison view. For example, I try to get the same degree of flexion PA views for knee patients who come back for osteoarthritis, so we can compare year to year. These need to be weight-bearing views to determine the extent of the osteoarthritis. Non-weight-bearing views don't really help us a great deal in osteoarthritis of the knee. Special studies include MRI scan with or without gadolinium, either by vein or intra-articular gadolinium. In the upper extremity for a slap tear, you might consider, if it's a failed repair or a slap tear, intra-articular gadolinium. In the hip, intra-articular gadolinium is used in certain situations to determine if it is an intra-articular problem. If they do intra-articular gadolinium and lidocaine, if that helps the pain and they may have something going on labral, that's a better indication that surgery is going to help them. Also, CT scan, more to look at the bone, and ultrasound can be helpful for tendons about the joints, not as much for stress fracture itself. When should an MRI be attained? Recent trauma, difficult physical exam that doesn't match the clinical symptoms, something that seems out of the ordinary, normal radiographs with significant symptoms, preoperative planning, or a recent MRI that was technically suboptimal. So we don't have to get an MRI scan with every musculoskeletal injury, but it seems that MRI scans are over-ordered. In my opinion, as an orthopedist, the best thing to do if there is confusion from a primary care physician is to consult the orthopedist first and let the orthopedist decide about advanced imaging, because sometimes it doesn't really help us a whole lot to have the MRI scan. For example, in somebody over age 50, the meniscus is going to be abnormal if we do an MR of the knee, so that may not impact our treatment or change our treatment if they have significant arthritis. So get a consult from an orthopedist prior to advanced imaging if there are any questions. Martin Schwartz, clinical professor of radiology at University of Alabama, Birmingham, did contribute to these slides. How should the MRI scan be performed? Need the best possible equipment, dedicated coils for that body part, contrast when necessary, correct sequences to define appropriate anatomy, and this is something that you have to have a radiologist that knows the musculoskeletal system and can set these up for the busy practitioner. The shortest exam to achieve results and keep the patient comfortable. Contrast administration. Intra-articular contrast gives superior soft tissue contrast and significantly enhanced diagnostics capability. For example, with a slap tear, you may have a normal shoulder MR that won't show up unless you do certain positions, like maximal external rotation abduction or forward flexion, adduction internal rotation. But the intra-articular gadolinium also will help us pick up a slap tear that may be missed if we don't use the intra-articular gadolinium. Intravenous contrast is useful for postoperative menisci and tumors. It's always good to talk to the radiologist if you have any questions, and make sure you make the order clear when you order it in your EMR so that they will get the appropriate study and do it once. MRI scans. It is important to communicate with the radiologist. If you're doing hip MRs, this radiologist should be skilled in hips. Now there are better results if we use intra-articular gadolinium. The lidocaine confirms an intra-articular process of the hip. The gadolinium outlines the labrum better, so you can do both intra-articular injections with lidocaine and gadolinium. If you have a small magnet open scanner in the hip, it's unreliable except for obvious disease like avascular necrosis of the femoral head. The high-resolution MRs are better for detecting hip problems such as a labrum tear or tendon problems about the hip. You really need a 1.5 Tesla magnet, a surface coil. The reliability is improving. There is indirect evidence. Most reliable is if they have an effusion, a paralabral cyst, subchondral cyst. That indicates that they have something intra-articular like a labrum tear or early arthritis. MR is most helpful for labrum tears, articular cartilage defects, ligamentum teres tears, impingement, capsule, and iliofemoral injury. So these are some of the examples of the machines and what they look like. This is a 1.5 Tesla machine. Claustrophobia can be a problem, but the open magnets aren't as good a magnet as the closed ones. This is an open 0.35 Tesla magnet. This can be okay for certain joints like the knee, some shoulders, but it won't give you the definition with hips or for a labrum tear of the shoulder. This is a dedicated extremity magnet that's a 1 Tesla. So the bottom line is make sure that your imaging center you are sending patients to is of high quality equipment and a musculoskeletal radiologist that you can communicate well with so you can get an appropriate study to give you the diagnosis as an aid to your history and physical exam. So with radiographs and with taking care of patients and interpreting the radiographs, you look for what you know and you find what you look for. So advanced imaging is definitely indicated if something is unusual, out of the ordinary. In my opinion, I would seek consultation from those who you trust, and a good orthopedic consultation is better than a lot of advanced imaging that may not give a diagnosis. Seek earlier consultations rather than getting more radiographic tests. If your orthopedist wants every test imaging done prior to being seen, I would suggest having another orthopedist as your consultant for that particular patient. Thank you very much for your attention. Water bucks in Africa.